Welcome to the fourth in the series of the Vulval Pain Society free webinars, which we're running for free at this time. We've got more to come every Friday at 2 p.m. in May. Last month we had Dr. David Nuns, consultant gynecologist, Dr. Liz Venner, dermatologist, Mary Chestnut, advanced pelvic physio. If you haven't had a chance to watch those and you'd find it useful, then get in touch with us at the Vulval Pain Society.
info@vulvalpainsociety.org.uk.
And we'll also be putting them up on our website shortly. Today, you've been kind enough to send me in a whole load of questions to answer. My name is Sheren Gaulbert. I'm a trustee of the Vulval Pain Society and a pain science educator, encouraging clinicians to follow current scientific guidelines and treat patients ethically. We also find through controlled trials that neurophysiology education can result in better outcomes for patients too. So some of you will know that I suffered with vulvodynia and vulval pain at its worst for about 10 years until I then started recovering. I also am a trained cognitive hypnotherapist, pain relief specialist. So we've received well over 100 questions. Some of the questions have been answered in a previous webinar, so do look those up. We've got about an hour today. The good news is we've got more experts coming up each Friday, so any questions I don't get to answer today will be answered by those experts, and more on that a little bit later. A number of questions have come in about my personal journey and my story. And whilst there's a real value in hearing patient voices, it's not really what today's about. Perhaps in future, we'll look at having an expert, a patient panel. In short, my journey after trialing various therapies, I found the jigsaw of therapies that worked for me. And that for me was self-hypnosis, cognitive hypnotherapy, physio. Without the previous two, the physio wouldn't have been possible, and yoga. And that's not necessarily going to be the route that's going to be most useful for each one of you. It's finding the jigsaw of therapies that's going to be most useful to you. So I'm going to dive into the questions that we have here. How long did it take Sheren to learn how to control her nervous system? What technique worked for her the best? And another question, is it possible to alleviate pain forever, or will it always be there? How did you overcome your pain? So, as I've alluded to, there's no one size fits all. You're unique. The best care that we have is an interdisciplinary approach. So a number of things that treats you as an individual and your individual experience. And that might be physio, that might be seeing a dermatologist and someone to work on the psychological side too. But that jigsaw of different therapies is going to be unique to you. How do I know that there's light at the end of the tunnel? Is it really around accepting only minor recovery, and how can some totally resolve and others not? Are there different conditions or causes? So we'll dive a little bit deeper into those. Light at the end of the tunnel, most women do experience relief, whether it's complete relief and they're pain-free and they're completely comfortable and they're getting on with their lives, or for some people it's more that the pain almost moves into the background somewhere, so that it's not really bothering them anymore, and the focus of attention is more on the things that you can do. And so that journey is going to be different for each one of you. To what extent do you think vulval pain is structural, i.e. the result of nerve damage or psychosomatic? Okay, now this is a really good one to get out of the way straight away. No one is imagining their pain. All pain is real. It's a real experience. The key thing, however, is that pain isn't really located in the body. So you might think, you have vulval pain or pain elsewhere and you think the pain is there. Pain is really more an emergent property of you as a human being. Psychosomatic isn't a term that we use anymore. There's a lot of confusion around that. The International Association for the Study of Pain defines pain as being always a sensory and an emotional experience. It's not one or the other, it's always both. They also say that pain is always a subjective experience, i.e. it's personal to you. No two people experience pain the same way. So pain is always a subjective experience that is influenced to varying degrees by biological, physiological, psychological and social factors. So the biological factors might be that there's something going on, there's an acute event, or it might be that there's chemicals running through you. That's biological too. The psychological, there's influence to varying degrees by biological, psychological, and psychological doesn't mean you're imagining it. Again, if there's something psychological going on, there's something emotional going on, there's still a biological basis there. There are still chemicals running through you. And social factors, so the context you're in, the people you're with, and the wider environment. So absolutely, you know it's not all in your head, and no one should ever intimate that. You know, you're not imagining your pain. But the key thing to remember is that there's no separation of the head from the rest of the body. And in here, you do have a physical structure, your brain. And it really kind of controls so much of what's going on in your body. Now, there's no separation here. So you've got your brain, your spinal cord, and your nervous system. And the brain communicates to your body via this information system, your nervous system. And it can also choose to receive messages up from the nerves, from the body itself, if it wants to. It can also just shut down receiving any messages from the nerves whatsoever. Ultimately, the brain decides. Does pain always mean something is wrong? So back to that question of to what extent do you think vulval pain is structural? So I think it's important to distinguish between persistent pain, what we used to call chronic pain. We're veering away from calling it chronic pain because chronic makes it sound like it's something chronic. It sounds like it's going to go on forever. Persistent is more accurate. Persistent pain is persisting, but it can ease. So the difference between persistent pain and acute pain is going to be important here. If pain is persistent, and that's your experience, then of course there's something wrong, but I suspect you mean, is there something structurally wrong? Well, quite probably not. There's no or little correlation between the severity of the pain that you experience and any structural anomalies. So you might see something on the skin, or maybe you might see something on an MRI scanner, but there's no correlation between what you see and the level of pain that you experience. Is a bit more complex than that. You will find that most healthy people will have some sort of anomaly showing if they're put in an MRI scanner, but most of them will not experience pain. This is really important. Persistent pain is more to do with what's happening within the nervous system. So acute versus persistent pain. If we think of pain as a protective response, it's an alarm, and it's signaling that there's something threatening, there's danger or potential threat going on. So in acute pain, that's very accurate. It motivates you towards taking action. So if you have an infection or thrush or something going on, that you're motivated to take action and so that you recover. In persistent pain, things are a little bit different. Tissue injuries and tissue damage, they tend to heal pretty quickly within a few weeks. Anything that persists for 3 months after any tissue injury healing time, that usual tissue injury healing time, is deemed persistent pain. So I'm going to make this analogy, which you may have heard before, of a fire alarm. So if an alarm goes off, you are motivated to take action. So the fire alarm goes off, you're going to assume there's a fire, you're going to call out the fire brigade and they're going to come out and put out the fire. Brilliant. But in persistent pain, this is like an alarm that goes off in the absence of fire, or just because you turned your oven on or turned your kettle on, or there's nothing going on at all, but the alarm is still on. Now, in that instance, you're not going to call out the fire brigade. You need to turn to someone else. The treatment is different. You're looking at people who can calm down the nervous system. So let's take the example of I've hit my thumb with a hammer, and that's acute pain. And what will happen is there's a signal that goes from the nerves via the spinal cord up to the brain. Now, it's a little bit more complex than that, but I'm just going to simplify it for time's sake. And the brain then will decide what to do with that information. And it will either decide, yeah, this is dangerous, something's happened here, and release amplifying chemicals that amplify that alarm. Now, that original alarm going up from the thumb isn't one that you perceive or feel. It's just for your brain to deal with. And only once the brain has decided that it's dangerous will it release those amplifiers. Once the thumb has healed, then those amplifiers can calm down, and those amplifiers are needed for you to motivate you towards taking action. But what if my thumb's healed and the pain continues? What's going on there? So I'm going to share a slide with you. I'm hoping that you can see that clearly. So if the thumb's hit with a hammer, then up the messages go up to the brain, and the brain then decides what to do with the information. And it goes on past perceptions of experience in similar contexts. If you've hit your thumb with a hammer before, perhaps you've seen someone else hit their thumb with a hammer before, or you know that that is going to hurt. You have a belief that it's going to hurt. And what do you then do? The behaviors you might have perceived as being successful in other people who might have hit their thumb with a hammer, or if it's happened before. And the attitudes of others, so other people around you, their reaction can contribute to what the brain does next. Now, the correct response in that instance would be for it to release amplifiers, and you then have that pain experience. But in persistent pain, it's kept going. Something's happening that's keeping this going. So what is that something? So let's have a look at some of the things that can keep pain persistent. And I would have a look in your life to see whether any of this is going on. Because just because there's tissue damage, or in the absence of it, that alone isn't enough for the brain to release these amplifiers. There can be other things going on. And so any of these emotions, anything that tips you into fight or flight, that releases adrenaline, cortisol, stress, anxiety, anger, frustration, feeling shame or guilty. You might be depressed, feeling helpless or hopeless, and poor sleep quality comes in here too. All of these things can lead to your brain deciding, yeah, there's something dangerous going on. We're going to release some amplifiers. And it can sustain this over a period of time. So have a look within your life to see whether any of this is going on within your life. And as well as fight, flight, or freeze, here are some other things. And I've noticed the questions coming in about expectation and anticipation. Yes, expecting there to be pain, for something to be painful if you do it, anticipating pain. If I take this action, if I wear tights, if I sit in this position, anticipating that, having that negative future focus is one of the key indicators that something becomes persistent and remains persistent. So have a look within your life if you have that expectation response. There are great examples of this and plenty of tests that have been done. Actually, one event you might have heard of, a builder who had one of these really long nails go through a steel toe-capped boot, and he was in absolute agony and taken to hospital screaming in pain. But when they examined him, what they found was that nail had completely missed his foot and his toes. But his pain experience was very real. And what had happened there was an expectation response. He'd anticipated it was going to hurt. He saw the evidence that this nail had gone in through his boot. Therefore, this must be very serious. That's how his brain had taken it. So notice that what goes in isn't what comes out. There was nothing going in through the nerves at that point in his toes because nothing had happened, but his brain had still had that anticipation, that expectation response, and released the amplifiers. There was another experiment, I think it was Oxford University, where a cold rod was placed upon participants' arms, which for many they experienced after a period of time as a kind of pain experience. And they were all hooked up to then morphine, and that kind of dampened things down. And after a while, half of them were told that the morphine would be withdrawn, and so that they might expect more pain. And that's exactly what happened. In that group that had the morphine removed, they experienced more pain. And when the experiment was over, the whole group was told that none of them had been on morphine in the first place. None of them had received morphine. The expectation that they were receiving morphine had dampened things down. The brain had decided to release muting chemicals that muted any alarms so they felt comfortable. And then in the group had the morphine taken away. Of course, there was no morphine to start off with. They anticipated that there'll be pain, and the brain decided this was dangerous and released amplifiers. So there are other things too. The nocebo effect is when you've been given an out-of-date message, either by a clinician or perhaps someone else around you, telling you that things are going to be like this forever. And I was talking to a patient the other day about this, and she had been told that this is it. You know, you'll be in pain for the rest of your life. And we know that that absolutely isn't the case. So attitudes and beliefs, catastrophizing, negative thinking, I'm a little bit averse to calling it catastrophizing because, of course, if you are experiencing persistent pain, you're going to be having challenging thoughts. But those very thoughts can amplify things and sustain this experience of pain. It can release even more amplifiers into your system, into your body. Avoiding behaviors, avoiding taking particular actions is signaling to yourself that actually that action might be dangerous. And if you're avoiding moving or doing certain things, there are knock-on effects there too. We'll have an expert on next week talking more about avoidance. And dissociating from the experience, some people feel like they can't even experience the good emotions because they are trying to dissociate from that experience of pain. Mirror neurons, so when you see other people hurting, and this one's important, if you are in a support group or an online forum, unless they are focused on action-based viewpoint, then it might not be useful for you to belong to those. If you're sitting around just talking about doom and gloom and how awful things are, then it only heightens things. And of course, you are going to empathize because you have a similar experience going on. So watching out for where you're hanging around in a way and getting your information. And your current focus of attention, if you have this hypervigilance and you're always focusing in on the area, rather than external to you, that also amplifies things. So there are a few things there that give you a clue as to what might be sustaining the pain experience. So does depression contribute to physical pain? You noticed perhaps in that list that yes, it can. It is a comorbidity. We do see it in certain women, depression and anxiety as well, and any kind of stress. Can nerve endings unlearn and forget the pain? This is a great question. Now, I'm hoping you're beginning to understand that actually there doesn't necessarily have to be any messages going up from the brain, from the nerves at all, in order for the brain to release amplifiers, because there are all these other factors involved. And we find that, you know, with phantom limb pain, you can have a limb that's amputated, but that person, in most cases, may experience very real pain in their phantom limb. It is a real pain. It's not imagined. The brain is still releasing amplifiers into their system. So you cannot have a body part, and you can have an operation to remove a body part, but you can still experience pain because, of course, the brain is still there. You can remove the brain and you absolutely probably won't feel anything at all, but we're not going to recommend that. Now, can nerve endings unlearn pain? So let's say the nerve endings are sending an alarm up. Now, there is, when something has become persistent, the nerve endings can become hyperactive and keep sending these danger messages, these alarms up to the brain far too regularly, and finding things in your environment that ordinarily to most people would seem safe, that it now finds potentially dangerous. If I see a hammer after I've hit my thumb with a hammer, I might see that as dangerous. I might be on high alert. What I then believe about the hammer's dangerous. So the receptors can become hyperactive and send too many messages up to the brain. However, those receptors on the nerve endings only have a lifespan of around about 6 days, and then they die and new ones grow in their place. Now, what this means is that there's an opportunity in that 6 days, if you're doing something to calm the nervous system, for once those receptors die and the next ones grow, for things to be calmer, for those receptors to be less hypervigilant, less likely to send all those messages up. So every 6 days, there's a new cycle. And if you can do something to calm your nervous system in that time, then yes, the nerves, those receptors are learning something new, they're calming down, and things can generally calm down. Can I control chronic pain just with my brain? Great question. Possibly. Looking at all of those factors that I went through would be a good place to start. And again, a multidisciplinary approach is key, and usually the best way to treat things and to calm things down. What treatment do you suggest for vulval pain? Again, multidisciplinary. If centralized pain is an unconscious process, it's an automatic process, is it possible to gain conscious control of it? This is a great question, because you're right, it's an unconscious automatic process that's going on. How can you gain conscious control of it? Actually, the aim isn't really for you to gain conscious control of it. Understanding why it's happening, what is activating this amplifier release, is going to be important. Once you've figured out, okay, I've got these things that are causing stress, anxiety, I've got this belief going on, I'm avoiding this. Once you've revealed what those amplifiers are for you, and for each person that's going to be different, then it's about what action are you going to take to change that. And do it one thing at a time. Take the smallest one and work on that and calming that down at a time. And if you need to see a therapist, do that, or if you can do breathing exercises or yoga or whatever it might be, take one thing at a time and work on that. Most responses are learned, and behaviors too. So if you think about brushing your teeth, most of you won't think about how to brush your teeth anymore, but when we were children, we were taught how to brush it. We had to really think about picking up that toothbrush, putting the toothpaste on, and the action you've got to take to brush your teeth. So you're learning to brush your teeth. But once you've done it with repetition, it then becomes unconscious, it becomes automatic. So the key to all of this is repetition. When you've figured out what an amplifier is, what's amplifying things, then working on changing that, then repeating that changed response over and over and over again. Challenging thoughts, and things like that, again, reframing and changing those and doing that over and over and over again. And if you need help with that, then absolutely seeking help from a qualified therapist. What do you believe the root cause of vulvodynia to be? Well, there's no one cause. It's individual to you. Again, looking at those amplifiers, what kind of mix of amplifiers you have in there is going to be important. Are there different causes of vulvodynia, i.e. muscular versus microbiome? Absolutely. And actually the microbiome is an interesting area, and there is a lot of research going into that area, and fascinating things coming out. Certainly irritable bowel syndrome, IBS, is a comorbidity for some women, and that may even predate any kind of vulval pain. So it is an area that there's work going on. And again, we have an expert coming on in a few weeks who may talk a little bit more about that. How does provoked vulvodynia fit into the chronic pain idea? I can't re-educate my nervous system to ignore the stimulus. Well, again, it's not about ignoring the stimulus, it's working out, well, whatever the stimulus is, what's the reaction the brain is having? Why is it seeing or assessing that stimulus as being a potential threat? And then working with the appropriate therapist to uncouple that stimulus and produce a new process, so that stimulus then becomes something safe. And something like graded motor imagery, imagining what you might be like with that stimulus. So let's imagine you can't sit down for a long period of time. Then what you might do is imagine that you're sitting down for, let's say, a short period of time, maybe 10 seconds, 20 seconds, and imagine it just to the level where you can imagine it looking comfortable for you. And if it doesn't look comfortable, then make it 10 seconds or 5 seconds, whatever it is. And imagine that through the day, several times a day. And then maybe about a week later to go ahead and sit down for that length of time and notice what that's like, and only for that length of time. And so you're desensitizing yourself. And I'm just giving one example of just sitting down there. So graded motor imagery, what you're then doing is slowly building up that visualization exercise, and then slowly desensitizing, being able to sit down or do whatever it is. So you can then maybe work with someone who will ensure that becomes more unconscious at a more unconscious level, and maybe a cognitive hypnotherapist or a physio who practices graded motor imagery, GMI. Okay. What distinguishes between different kinds of vulval pain emotionally? Okay, well, emotions play a part, as you've probably gathered. So anger, frustration, guilt, shame, sadness, any kind of stress. but I'm not sure exactly what you're asking there, but we can't really distinguish whether one emotion causes one kind of pain. I don't think it works in a linear fashion like that. You know, the anger causes one kind of vulval pain, anxiety another. It's not going to be linear like that. Why does it feel sore all the time? Now, this is important, and this is about noticing the little differences, because persistent pain is not really at a constant level. It's changeable, it changes. So there are going to be times where it feels worse and times where it's a little bit better. So you might focus on the times that it's at a lower point and maybe work out what's made the difference. Enjoy it being lower. Focus on things that you can do. And I'll be talking about things that you can do that mute the response as well later. How to control chronic pain due to arthritis in big toes and index finger. I hope you're in the right place. I'm assuming you experience vulval pain too, and sorry to hear that. There's no correlation between anything structural like arthritis and the pain experience. So again, go back to what might be amplifying things. What's putting you into fight or flight? What's the stress? What's the anxiety? What are the beliefs? Do you have a belief that because you have arthritis, you'd experience pain? Again, undoing that, and some re-education might be important there. Okay. All right, how to calm a flare up and thrush at the same time. Okay, so you've got two things going on there. If you have thrush, then that's an acute event. So the amplifiers are playing a really good role. They're flooding your system and it's helping you take action, and it's doing important work. So pro-inflammatory cytokines are going to be cleaning the area too. So all of that is good. Unfortunately, what that means is that, you know, it can then have a knock-on effect with your persistent pain. You might experience persistent pain amplified too. Interestingly, for some people, it switches off the persistent pain completely. And because the acute event is so big that it needs that attention, and it really gathers up your focus. And so for some people, in fact, that because the acute event is so big, that the persistent pain disappears altogether. So time with that one, let the acute event, the acute thing heal. Coping with pain left from vaginal shingles. Okay, now this one's slightly different. It's a gentle progress, and you might use a visualization technique for this. Anything that you might imagine calming the area. So what's that kind of pain that you've got like, and using a visualization technique to imagine it calming down. So it feels hot, you might imagine something cold cooling it down. It's one that can ease over time for you to notice a difference. If we do have time, I'll go through something later on. If not, perhaps I'll record a video nugget to guide anyone who might be interested. Why do flare-ups keep happening even though I've had this illness for 20 years and have a good handling on it? Okay, well, you know, sadly, you know, I've worked with women who've had this for, just trying to think, the longest one was 60 years. And she seemed to have a pretty good handle on it. But actually what hadn't happened is all the amplifiers hadn't been identified. So identifying what was happening in your life around about the time or in the months leading up to you experiencing vulval pain for the first time. What that meant that there were already amplifiers in your system. And that might give you a clue as to what you need to work through. And then what amplifies in your system now, so that you're working on the current thing too, and what expectation might you have of the future. So a few things to work through there. Making sure you're pacing and not overdoing it, and certainly not engaging in boom-bust behavior. We see quite a bit of that. So on a good day, you might do lots and lots of things, But unfortunately, all that does is if you overdo it, then your nerves are kind of then going on high alert and more adrenaline, more of those amplifiers, and then it just kind of wears you out, and then you might then have more of a spike, and then you end up doing nothing at all. So refrain from that boom bust behavior and being more balanced. So you might know of this analogy of a bathtub. So if you think of this dripping tap, and the dripping tap into the bath, the drips signify these amplifiers, and the bathtub is your body. So these amplifiers we talk about is filling up the bathtub. And of course, if the bath plug is pulled out, hopefully it will drain out and you'll be okay. But if the bath plug is in and you're suppressing your emotions and you're not talking about it, or useful things aren't happening, or you're wearing a mask and pretending everything's okay, then the bath plug's in, and this is going to overflow pretty quickly. And at that overflow is where we see persistent pain and you experience your symptoms. Or it might be the bath plug's out and you are releasing those amplifiers, but they're flowing in really quickly. So again, it hits overflow and you experience pain. So boom or bust behavior, again, fills up that bathtub pretty fast, and it hits overflow. So what can you do to reduce the level in your bathtub? And know that for a lot of women who haven't found the kind of jigsaw of therapies that work for them, the level of those amplifiers in the bathtub, that bathtub may be half full or just sitting underneath that overflow level. So it only takes a couple of drops of adrenaline for it to overflow and for you to experience pain, which is why looking for, or what is it that I did that has caused this in, I sat down and maybe that's caused it, isn't really useful. With persistent pain, it's a lot slower. So it's more useful to look at what have I done in the last 2 or 3 days that have filled up this bathtub. What tips can you suggest in keeping pain lower? Okay. Well, you'd have heard me talking about these muters, and essentially your brain can decide, regardless of what the nerves are sending up, or even in the absence of any messages going up, to release these muters and calm things down. You won't know anything's gone on. And the most powerful synthetic painkiller that we have, morphine, the brain produces muters that are around about 60 times more powerful than morphine. Just take that in for a moment. The brain releases muters that are around about 60 times more powerful than morphine. Now, I am not suggesting for one moment that you want to release all of those at once, because you'll probably just be asleep. But learning how to release those muters is going to be useful. And you've got a whole load of them. Endorphins, and you get those from laughter or being on the edge of laughter. People think often that if you exercise, you get endorphins. Actually, for some people, for many people, to have an endorphin release, you'd need to have overdone it with exercise to get that endorphin release. So we wouldn't recommend that. Laughter was probably a better one, doing something that you enjoy. Serotonin is another muter. So the sunshine is a natural way of getting some serotonin. If you're receiving attention, and from someone you appreciate getting attention from, that releases serotonin. But just make sure the attention you're getting is not because you're experiencing pain, but just because for you as a person, or because you've taken some kind of positive action. So you might even want to coach the people around you, rather than them asking you, how are you doing today? To ask, well, what did you do today? What action did you take today? So you're focusing more on the positive and getting positive attention. Dopamine is a good one. That's a very good muter. And you get that anytime you're taking action. And rather than thinking of the bigger goal of I want to be pain-free, the question to yourself might be, well, if I'm pain-free, what things might I be doing? And then bringing it all the way back towards now, and what one small thing might I do as a tiny step towards that? And anytime you hit a small goal, you can get a hit of dopamine. So focus on the small goals, manageable chunks. Oxytocin is a nice one that you get from being around people that you trust. And I know in this time of lockdown, we may not have that ability to hug someone in person, but if you have a pet, that can work too. And certainly Zoom, Skype, FaceTime, being in contact with people, even on the phone, just that precious time with someone that you trust, or an animal that you trust, can give you that oxytocin. So releasing muters and seeing how you can bring that into your day. Okay, so we've got a few things on how to manage flare-ups, calming flare-ups, how to calm down a hypersensitive nerves. There are lots of things you can do here. Breathing is a good one. And belly breathing in particular is a good one. And I know our speaker next week will probably touch on that and give you some practical pointers on belly breathing. One way to do it is imagining you've got a balloon in your stomach and you're breathing in gently through your nose. And as you breathe in gently through your nose and slowly imagining this balloon just inflating in your belly, and then breathing out really slowly through your mouth, letting that belly deflate. And we find if that belly breathing moves the pelvic floor muscles far more, so there's that movement there, which is really beneficial. So that belly breathing. And the out breath to be longer, which stimulates your vagus nerve, which means the opposite of the fight or flight branch, the safe mode, the parasympathetic branch of the nervous system is activated, so that you get muters. So just practicing gentle belly breathing can be really useful. And there are lots of different breathing techniques. I think someone's asked, do you use the 5-7 breathing technique? Yep, you can use 5-7 breathing technique, 7-11 breathing technique. Whatever works for you, as long as that out breath is longer, you can benefit in just doing that for a short while. Other things you can do to calm down the nervous system is imagining being in a calm place, whatever that calm place might be for you. And it might be we release a video nugget of me just taking you through something, or again, one of our next speakers might be able to take you through something too. Imagining being in a calming place, or a calming meditation, or finding something on YouTube. Something that you find enjoyable can calm things down. Tips on how to ease anxiety when flares arise and how to stay positive. One of the things you could do is catching your thoughts, which is a CBT exercise, catching any negative thoughts, any challenging thoughts, and getting them out of your head. Because if they're running through your head, they're taking up a lot of space and energy, and it's just keeping the cycle going. So get those negative, challenging thoughts out of your head and assess them. Once you see them in black and white, is this true? Can I know this is 100% true? Is there an alternative or a different way of looking at this? What might be a different way of looking at this? So reframing those thoughts might be a useful thing to do. Can you give general tips about maintaining a feeling of calm? Yeah, I mean, again, there are lots of things. I hope you've got some ideas as to how to release those muters. Keeping anxiety at bay. Sometimes it's not about ignoring the anxiety. Sometimes it is about kind of leaning in to the anxiety and almost just having a conversation with it. Hello, anxiety. What is it you want me to hear? Is there a message here? What specifically can I do that can ease you? Sometimes the very action of moving away from the anxiety and trying to ignore it can amplify things, that avoidance. So sometimes leaning in, you might try that on your own or with a therapist. And then what positive action you might take. Tips for reducing anxiety around intercourse after years of living with provoked vulvodynia and vaginismus. Again, graded motor imagery can be really useful for this. Graded motor imagery, and then working with a physio, breath work, reframing thoughts, looking at beliefs, maybe working with a psychosexual counsellor on that one. How often should mindfulness be practiced? That really depends on what specifically you're practicing. Mindfulness can just, doesn't necessarily have to be your on an app. You can. There are lots of apps out there, mindfulness apps that you can follow. It might just be sitting still and noticing what's in your environment for a few moments. One thing you can see, one thing you can hear, one thing you can feel that's a nice, pleasant thing for you to feel. Maybe one thing you can smell or one thing you can taste. Just brings your focus onto the sensory experiences, and that in itself is mindful. And takes very little time, so it might just be a minute. So it depends what you're practicing, and finding what you enjoy. So there's no right or wrong way of doing that or practicing mindfulness. It's not necessarily a doing thing; it's a being thing, or just being mindful or in the environment you're in. I'd like to meditate or visualize, but I'm so preoccupied with pain that I can't sit. If I lie down, I fall asleep. Any suggestions? Well, I wouldn't lie down if you're meditating. I would sit down with your feet firmly on the floor, your back supported, so that you don't have that kind of possibility of falling asleep. If you're still falling asleep or you are that preoccupied, then perhaps an external focus might be better. A lovely exercise, a bedtime exercise, 3 gifts, is at the end of the day at bedtime, reflecting upon your day and just picking 3 nice moments, 3 moments that you enjoyed in whatever way, whatever small way, and jotting them down. And it might just be that the sun came up, or you heard birdsong. It may be as simple as that or as small as that, whatever it is, and just jotting those 3 things down. You might even link it with why you value that, if you wish, or the good feeling that you get. I heard birdsong and it gave me a lift in my heart, So keeping it simple, and external focus might be a better idea. And it's a lovely thing to do anyway at bedtime, because as you sleep, your brain's processing the things that's happened in the day or the couple of days beforehand, the things that might be on your mind or in the back of your mind. It's processing that. So if you go to bed reflecting on 3 lovely things, then it's a much nicer way to fall asleep. And if you can't find 3 things, this can be a challenge when you first start for some people. Anything more than nothing is something positive. So even if you just find 1 of the 3, it's meant to be a bit of a stretch. If it's really easy, then add in another step and figure out why it's important to you. So when you're stretched a little bit to find those 3 gifts, or why it's important to you, or the good feeling within you, when you're stretched, you get that dopamine, which we know is a muter. Is it best to rest or move when having a flare? That really depends, and you would know your body best. Motion is lotion is a lovely saying. Keeping on moving is a really good thing for your body. But know your limits. Know how much is okay for you to do, but don't stop completely. Is it possible to stop negative thoughts and reduce the impact of the level of pain felt or the flare-up? Again, this is about acknowledging your thoughts, get them out of your head and reframe them. It's rare that things are black and white, so look for the shades of grey or the rainbow colours in between. So I would reframe those thoughts, get them out of your head. again, so it's not necessarily about stopping the negative thoughts, it's acknowledging that they're there, and then how can you see this differently? How can you see it from a different perspective? How to change my brain registering nerve pain from active abuse years ago. Okay, all right, so again, this isn't the brain isn't registering nerve pain. The nerves might be sending a message up or not at all. Ultimately, the brain kind of decides whether to release those amplifiers based upon the context you're in, the environment you're in, the people you're with, the things you're thinking about, your beliefs. So again, all of those things, those amplifiers we talked about. I would suggest seeing a therapist for this one, for some type of trauma therapy, maybe EMDR. Eye movement desensitization and reprocessing can be useful for trauma, or a cognitive hypnotherapist trained in AMDR, which is an updated version of EMDR. So I would probably suggest that. That takes us on to the talking therapies questions. What complementary therapies do you recommend? Okay, well, what suits one person may not suit another. Yoga, certainly mindfulness, cognitive hypnotherapy, self-hypnosis. These are all really useful, but it's finding the mix that's right for you. Okay, the best type of talking therapy, how to find it, and what qualifications to look out for. And then someone else has asked, finding a suitable talking therapy or therapy for vulvodynia. What does Sheren think works well? What should I look for, both in type of support and therapist qualifications? Great question. There's lots open to you when it comes to talking therapists. Again, it's finding the right fit for you and what might be most appropriate. So if you are concerned about having sex, then psychosexual counseling or a sex therapist. The place to go to would be the College of Sexual and Relationship Therapist, and in the replay you'll have the website. It's at cosrt.org.uk. So that's for psychosexual counselling, sex therapy. For cognitive behavioural therapy, the British Association for Behavioural and Cognitive Psychotherapies would be the place to go to. It's a babcp.com, babcp.com. Mindfulness, absolutely brilliant, at the right time. And the 8-week course might be something you look into, the mindfulness-based stress reduction course, MBSR course, which is 8 weeks, and there will be online MBSR techniques. Acceptance and commitment therapy, which is sits within cognitive behavioural therapy. It's an up-to-date part of CBT. So acceptance and commitment therapy, ACT, might be something useful to look into. And my favourite, cognitive hypnotherapy. And actually, for a cognitive hypnotherapist, the site to go to is the qchpa.com site, and again we'll put the details in the follow-up, in the video replay. Okay, so can hypnosis treat vulval pain? Yes, both traditional and cognitive hypnotherapy has its uses. It's finding what's useful for you. If you are working through beliefs and want to get back into living life according to your values, which we know is important, working through challenging thoughts, those automatic responses, working at that level, then I would suggest cognitive hypnotherapy. How does cognitive hypnotherapy differ from CBT? Great question. Well, cognitive hypnotherapy is quite a wide framework, and it hangs lots of other therapies within it. So cognitive and behavioural therapies sit within cognitive hypnotherapy, as do all sorts of interventions, Gestalt, mindfulness training, looking at the process your brain is going through to release these amplifiers into your nervous system and changing that. So ultimately where CBT is more of a conscious, rational thinking process, cognitive hypnotherapy is looking at the unconscious and those automatic processes and ensuring that things, when you change a behavior, that they become unconscious, and there's lots within that, lots that can be done. So it's a much wider framework, cognitive hypnotherapy. Is hypnotherapy available on the NHS? Not that I know for this, not for vulval pain, as far as I know, but watch this space. How can one go about finding a hypnotherapist who is experienced in dealing with vulvodynia? Okay, when we're talking about cognitive hypnotherapy, if you go to the QCHPA site, anyone on there, any cognitive hypnotherapist on there is trained to identify what is relevant for you regardless of your diagnosis. It is evidence-based, so I would probably have a look at that, but you don't need someone who's experienced in vulvodynia. Of course, cognitive hypnotherapists will have access to me, and what I would do is phone around and get a free consultation and have a chat to see what's appropriate for you. But there's lots of talking therapies that might be useful for you to have a look at. What's the number one piece of advice you would give someone who is in a cycle of chronic pain? Identify the amplifiers and identify what muters you can release. Is that 2 bits of advice? It's figure out the balance between amplifiers and muters. How can you decrease your amplifiers and increase your muters? That, I think, would be the number one piece of advice. Okay, so I can see we've reached 3 o'clock. And I know we've kind of rushed through quite a few questions, and there are lots more that have come in. I have got, if you're interested in learning more, I have a free resource, the 7 keys to reducing your pain. If you go to this site, again, the link will be in the video replay and sent to you. You can sign up for it and you'll receive a short email every day over 10 days, just going over some of the things we've talked about and a little bit more. So you'll learn a little bit more about amplifiers, more about muters, and some possibilities of how to release them, so giving you ideas. So that might be something you want to sign up to. Okay, so I hope that's been useful. Next week we have Amina Bahdouri. I hope I'm pronouncing her name correctly. Really excited. Next Friday, the 8th, Amina is a yoga and meditation teacher, and she is experienced in helping women with pelvic health issues. Really excited about this because one thing you probably have heard is me and all the other speakers at some point has mentioned yoga. So she'll be able to take you through some of the poses that might be useful, and probably do some breath work with you today too. So that's next Friday, the 8th at 2 p.m. And in the video replay, in that email, there'll be a link to register for that one. Looking ahead, Friday the 15th of May at 2 p.m, we have the brilliant Dr. Winston DeMello, consultant in pain medicine. Absolutely sign up for that one. His knowledge is absolutely invaluable. So that's Friday the 15th. Friday the 22nd, we're going to have a look at the questions and see what most of them are based upon and who might be useful. So we'll come back to you on who we have for that. Friday the 29th is the expert panel. So you'll have a panel, a multidisciplinary panel of experts answering any questions that haven't been answered up until then. And you might find that some of us have a slightly different viewpoint, and that's okay too. So that's Friday the 29th. And We are very thankful for your donations, and that means it helps us help you better. It keeps these going. So we're really grateful for enabling us to help you better. And after this webinar, you will be taken to a page where if you are able to make a small donation, we'd be absolutely grateful. And there'll be a link in the video replay at the bottom of the screen, as well as in the email, and any small amount will be appreciated. And we completely understand that some of you might not be in a position to give anything, and that's absolutely fine. So that's it for today. We hope to see you back here next Friday, the 8th, for our yoga and meditation teacher, Amina. Thank you for joining us. Bye for now.